My name is Dr. Ernest Tellerico, and I serve as Associate Professor of Anatomy and Cell Biology, as well as Associate Faculty in Radiologic Sciences at the Indiana University School of Medicine Northwest Campus. This is Radiology Module Number 1, Introduction to Medical Imaging Basic Radiology. Radiology is becoming increasingly important in the field of clinical medicine and diagnostics, as well as encroaching on the gross anatomy laboratory as well as the research arena in both humans and animals. It is therefore critical that the student physician have a basic working knowledge of different radiographic modalities as well as how to interpret various radiographic films. Here at the Indiana University School of Medicine Northwest Campus, I have developed a medical imaging program of anatomical donors or first patients. Within this program, every anatomical donor that arrives on our campus receives a full range of body plain film X-rays, as well as ultrasounds and high-resolution MRI and CT scans. These images are then loaded onto computers with image analysis software for students to use during the course of anatomical dissection, as well as learning how to use the software to interpret these various radiographic modalities. Even further, we learn more about our first patients and often see things that would be missed if we did not have these advanced medical images. And this kind of program also feeds into our cadaver-based research program here at the Northwest Campus. This is an example of one of the films obtained from this imaging program. This is a high-resolution or high-density MRI scan of the brain of Sandra Harrington. Sandra Harrington died from renal cell carcinoma. This is a T2 weighted scan of her brain, meaning that fluid should be bright and tissues dark. The scan has been color enhanced, reconstructed as a 3D film, and then flattened. What we see here, circled by the laser pointer, is a large yellow mass which actually represents an infarct of the right cerebral artery, or middle meningeal artery, to be more specific. In 1% of the patients that suffer from renal cell carcinoma, the cancer metastasizes to this specific location within the brain and causes an infarct in the middle cerebral or middle meningeal artery. It is the infarct in this artery that resulted in the death of this patient. Medical imaging allows the physician to visualize internal body structures, and it does so for the most part by using non-invasive techniques. By the end of this module, the student should have obtained a basic understanding of the methods used in medical imaging. He or she should be able to compare and contrast which imaging method may be most appropriate for the patient's situation. Also, the student should be able to skillfully approach and interpret the chest X-ray film, and then apply this method to other radiographic modalities. And finally, the student should be able to interpret advanced medical imaging films such as high-resolution CT and MRI scans. It is interesting for us to take a brief look at the history of radiology, where radiology as a medical science first began in 1850 with physicist Wilhelm Conrad Röntgen. Dr. Röntgen was the person credited with discovering the X-ray. If it was not for his work, we would not have all the common medical imaging techniques that we take for granted today in clinical medicine. In the 1900s, lantern slides were introduced. These were basically index card-sized pieces of lead glass crystal onto which the radiographic image was placed or impregnated. The slide would be placed into a lantern slide projector, behind which a candle, or later the electric light bulb, would project the image onto a white wall or a white bed sheet for interpretation by the radiologist. In 1946, the film cassette changer was introduced. Basically, this cassette is a case that holds a piece of radiographic film, X-ray film. It is coated on its inner surface with a substance such that when X-ray photons hit this surface, they are rapidly and uniformly spread across the X-ray film, allowing for uniform exposure. The cassette then with the film is taken into a darkroom where it is opened in the dark, and the film is removed and developed so that it can later be placed onto a shadow box where the image can be interpreted by the physician. In the 1970s, computed tomography or CT scan was introduced, and a few years later, MRI or medical resonance imaging. CT scan still uses X-ray radiation and is better for examining dense structures such as bone, whereas MRI does not use X-ray radiation. Therefore, it is a benefit for the patient who is radiosensitive or for the physician who does not want to expose their patient to radiation, and it is also better at imaging soft tissue structures. In the late 1990s, Digipan or digital radiography was introduced. Using this modality, the film cassette changer was replaced with a cassette that was really constructed of a computer chip. So the radiographic image or X-ray would be placed onto the chip electronically, and then the cassette would be placed into a digital cassette reader where the computer chip would be erased as the image or the data was transferred to computer and then to a high-resolution monitor where the radiologist could do the imaging analysis. These three images show different types of digital radiography systems. In the first on the left, this is a plain X-ray system, where the cassette would be placed in the bucky either under the table or in a vertical bucky if the patient was taking a standing film. In the middle, this is a C-arm surgical system, a surgical system that would be used in the surgical operative theater with the radiolucent table. Superiorly is located the X-ray emitter, and underneath the table would be the receiver, the detector, containing the cassette with the computer chip. And on the right is a modern fluoroscopy system, where the interventional radiologist can see images in real time in their patient, as well as actual movement going on during various processes within the patient's body. This is an example of the digital cassette that's used in modern radiography. And this is a digital cassette system. As you can see, the cassettes or computer chips come in various sizes, and the radiographer would select the appropriate size based on the physician's orders that specify which region of the body or what on the patient is to be radiographed. This is the cassette reader. So the cassette is placed into the reader, and the reader erases the cassette so the chip or the cassette is ready for the next use, literally in seconds. And the data is transferred to computer, and the image then appears on a high-resolution screen where it can be interpreted or analyzed by the radiologist. This is an example of one such image. This is a plain chest x-ray. It is a Japanese model or digital system that's being used here. I know that because the film is placed on the screen where this is the left of the patient and this is the right of the patient, so the cardiac silhouette is here. In the outside of the United States and North America, the films, when they are placed or oriented on the screen, or when the image is oriented on the film or on a monitor, it is not placed relative to anatomical position as it is in the United States and North America. This is an example of a 3D reconstruction using CT technology of a patient's skull. And in this image, this is very interesting. We have an ultrasound, a Doppler ultrasound, combined with a CT scan of the patient. And the specific area of the body is the abdominal aorta. Okay? And it's been color enhanced, and it's nice that they've labeled the various arteries here for us coming off the abdominal aorta. This is an example of high-resolution CT. It's a CT-guided needle biopsy. This is the needle and trocar or catheter, and this is the patient's lung. Can you see the lesion that's being biopsied? In this case, we've used the technology in PowerPoint to circle the neoplasm or the lung nodule that's going to be biopsied. This is a needle biopsy, so it will not produce a slice of tissue on a slide for analysis by the pathologist, but it will produce a smear of cells for cytological analysis. And again, this is a type of CT with 3D reconstruction. Do you know what condition is being shown here and whether this is a child or an adult? Think about it for a moment. Okay, this is a reconstruction of a child's skull. I know that because on the anterior side is the anterior fontanelle. And you see how there is this frontal bossing or bulging out of the forehead or front part of the skull. Seems like the skull is enlarged, and the patient suffers from hydrocephalus, or an increase or retention of the cerebral spinal fluid, and that can be caused by a number of conditions. This is an interesting film. It is a 3D reconstruction of a patient's skull, and in this instance the patient was involved in a bar fight, and his opponent took the leg of a bar stool that I'm pointing to here with the use of the laser pointer and shoved it through his jaw, through his face, and out the orbit. This, of course, is the endotracheal tube here, going down the patient's airway, and remarkably, this patient suffered no permanent injury. These are examples of lantern slides and the lantern slide projector. Recall the film cassette was later introduced in 1946. Before this, they used these pieces of lead glass crystal onto which an image was placed, and this would be placed into the lantern slide projector and the image projected onto the wall for analysis. In this presentation, we're going to discuss various radiographic techniques, the first of which is the chest x-ray, or capital CXR. This is how we abbreviate this, chest x-ray, and this is the most common film that's used in radiology today. We're also going to examine fluoroscopy, which allows us to look at movement or images in real time, bronchography, which allows us to examine the airway and the respiratory system. Cardiac catheterization, which is actually a sub-discipline of fluoroscopy. Coronary angiography, again, another sub-discipline using fluoroscopy. Computed tomography or CT scan. Magnetic resonance imaging or MRI scan, now abbreviated as MR. Positron emission tomography or PET scan. Ultrasound. 3D computed tomography and 3D or three-dimensional MRI. And finally, fusion technology, where a high-resolution CT scan or MRI scan is combined with some other modality, either ultrasound or PET scan. So let's discuss now how we go about interpreting or dealing with radiographs. And to do that, we need to understand some basic concepts in radiography and some terms. These include transmission, absorption, scatter, and attenuation. Transmission is the way in which X-ray photons pass through a patient and they are unchanged, meaning their energy levels are unchanged. So they go into the body and exit the body through a path, and their energy level remains the same. This is in contrast to absorption, whereas the photons of the X-ray beam pass through the body, some of the energy of the X-ray radiation is absorbed by the patient. And this depends on the thickness, the density, and the atomic number of the structure of which the X-ray photons are passing through. Scatter is a result where the X-ray photons are passing through the substance and they're deflected, or there's a change in direction of their path. And it also might be modified by a decrease in energy. And finally, attenuation. This is the process by which radiation loses its power or loses part of its energy as it travels through structures, matter, and interacts with that matter. Attenuation of X-rays in solids takes place by different mechanisms, some due to absorption and others due to the scattering of the beam. This is an example of transmission, where the X-ray photons travel along a path through the body and their energy levels remain unchanged. This usually occurs where the structure that they are passing through has very low density, such as air or gas. And what we see on film is an area of radiolucency indicated by an area of darkness or blackness on the film. This is in contrast to absorption, where as the photons pass through a structure, some of their energy is transferred to the patient or that structure, and therefore they enter and exit the body with different energy levels. The energy level on entry is higher than that on exit. And what we see on film are varying degrees of gray, and this depends on the thickness of the matter, the density, and the atomic number. Sometimes X-ray photons hit hit something that's difficult for them to pass through when they travel along a path through the patient's body. And in this instance, they not only lose energy, but they are scattered in different directions. This produces very distorted images on the film that make interpretation very difficult. And finally, attenuation is the process by which X-ray radiation loses energy or power as it passes through a patient and interacts with the matter of the substance that it is passing through. This produces varying degrees of grays and whites on the film when it is developed or viewed on the monitor by the radiologist. These next few slides are critical slides, critical information, and you, the student doctor, need to get it. You need to understand it. So in radiology, we speak of 5 densities. And these densities range from white, or most radioopaque, to black, or most radiolucent. And this occurs because of differences in transmission, absorption, scattering, and attenuation of the X-ray photons in their path from the source of the X-ray, the structure or part of the machine that we call the emitter, toward the X-ray detector, such as the digital cassette. The 5 radiographic densities going from most radiolucent or less dense to most radioopaque are air or gas, fat or adipose tissue, soft tissues such as skin and muscle, dense tissues such as bone, a specialized connective tissue, and metal objects. And you see here on the right, we are going from or moving from least dense to most dense, or most radiolucent to most radioopaque, most dark to most white. Air, fat, soft tissues such as tissue organs, muscle and skin, bone, and metal. These are the 5 densities of radiology. This radiograph shows us 4 of the 5 densities in radiology. The first thing that we need to do is orient ourselves to the film. This is something that you need to do, and you must never overlook this step, because if you don't understand what you are looking at, then any interpretation that you make is valueless and may hurt your patient. This is the same situation when you take a lab practical examination in the human growth anatomy laboratory. You need to orient yourself to the specimen, understand what you're looking at, and then try to make the interpretation. So here we have an AP, abdominal pelvic X-ray film. So it's a plain X-ray film, it's a flat film in the AP projection. That means that the X-ray photons are entering through the anterior side of the patient and exiting the posterior side. So the emitter is on the anterior side, and on the posterior side or the dorsum of the patient is the detector or the digital cassette. And when the image is placed onto the film or on the computer monitor for us to interpret, it is as if the patient is facing the interpreter or the radiologist and is standing in anatomical position. So this is the left side of the patient. This is the right side of the patient. Now we orient ourselves to some structures. Here is the vertebral column or the spine of the patient. We see some ribs bilaterally. This is the sacrum, which is still part of the axial skeleton, the left pelvic bone and the right pelvic bone, the right proximal femur and the left proximal femur. This is the pelvic inlet. These are the iliac crests, the left and the right. This marker here is what we call a Mitchell marker. In this case, it's telling us that this is the right side of the patient, and that the patient is in supine position when the film is being taken. That means that they are laying on their back on the radiographic table. Now let's look at the four radiographic modalities or densities that are shown: air or gas, fat and adipose tissue, soft tissue, and calcium of bone. So here is air and air or gas in the gut tube, We see some gas in the sigmoid colon going toward the rectum and then to the outside. Okay? Fat and adipose tissue we see in the lumbar regions here, and we see superimposed on that part of the gut tube. Okay? Other soft tissues such as muscle, tendon, and solid organs. This is the liver up underneath the right thoracic cage. Here is the spleen and part of the stomach. And then we have calcium, the calcium that we find in cortical bone. That's why we can see the vertebral column, the sacrum, the ilium, or the pelvic bone or part of the pelvic bone here. See the proximal femurs bilaterally. So these are 4 of the 5 radiographic densities. In this image, we see all 5 of the radiographic densities. And again, we need to orient ourselves. This is an AP pelvic X-ray film. So it's a plain flat film using X-ray beam of the pelvis of the patient, and it's in the AP projection, meaning that the emitter is on the anterior side and the detector or the cassette is on the posterior side. So X-ray photons are passing from anterior to posterior as they pass to the patient. So here we see, well, let's get orientated first. So this would be left and this would be right, superior and inferior. Okay? And here they give us a little marker. This is not a Mitchell marker, but it's an annotation that's been made on the film for us, L indicating left. So air in the gut tube, air and fecal matter mixed in the gut tube, in this case flatus, and air or flatus in the rectum. Okay? Fat or adipose tissue along the hips, bilaterally, and again, this is the pelvic bone on the right, pelvic bone on the left, iliac crest left, iliac crest right. We see the spinal column with the sacrum. We can even see the anterior sacral foramina bilaterally. Okay. We can see the distal parts of the pelvic bone, including the ischium, the pubis, pubic crest or symphysis. Actually, this is the crest here. Here's the symphysis, and the obturator foramen, and the proximal femur, the head, the neck, greater and lesser trochanter, the diaphysis, the proximal epiphysis. So we looked at air, we looked at fat or adipose tissue. Then we have to have other soft tissues. So here we have other soft tissues inside the pelvic cavity, and we can see skin and some superimposed muscle of the thigh, and then we have the calcium of the bone. You can see the bones, again, the pelvic bone and the proximal femur, and then we have metal. In this case, the patient has received a right total hip arthroplasty. We have the acetabular component, the femoral head component, neck, and the medullary shaft component. So here we have each of the 5 radiographic densities shown. These are both examples of CT scans on the same patient. Actually, on the left, we have what we call the scout view. For example, if you're at war, you would send out a scouting party to observe or survey the enemy covertly. And that's exactly what a scout view is. It's a survey view before we get to our detailed views using CT scan technology. And then on the right is a CT scan of the patient using a bone filter. So in the survey view, again, this is CT scan, so it does use X-ray beam. But in the survey view, we can see the patient's head is slightly turned to the left. We get our orientation: left, right, head or superior, and foot or inferior. We see bilateral total knee arthroplasties or knee replacements. Something's going on here. Okay. These are femur, tibia, fibula. You can see that bilaterally. The spine, dome of the diaphragm over the liver, dome of the diaphragm over stomach and spleen. We see some cardiac silhouette or shadow, and this is a pacemaker defibrillator. We can interpret that that's what it is because of the number of leads. There are 4. If we look at the bone window here, basically that's a filter that enhances the bone. We have a nice orientation marker for head, foot, anterior or front, L for left, so this is the right side of the patient. Again, the image is always oriented on film or on the monitor as if the patient is in anatomical position facing the interpreter or the radiologist. We have our pacemaker defibrillator here with leads. We see some bone spurring or osteophytes on the vertebral bodies, indicative of osteoarthritis. We see some arthritic change here bilaterally on the iliac crest. And then we see something strange here happening and here. This is an example of scatter at the knees. You know what's happening here. Take a moment and see if you can interpret what's going on where I'm circling with the laser pointer. If we go back to our scout film, we see some metal objects here, and what's happening in the bone window is that, like the metallic components of the knee replacements, the X-ray beam is being scattered. This is an example of scatter, and it's being scattered by something within the scrotum. And these are clips on the ductus vas deferens used for fertility control in men, and that's what's causing the scatter here on the film using the bone filter or the bone window. There are 3 common radiographic projections used in radiology. The first is the PA or posterior anterior projection. The second is the AP or anterior posterior projection. And the third is the lateral or LAT projection. And projection refers to the direction of the X-ray beam as it passes through the body. So in the PA projection, the beam is passing from the posterior to the anterior. So emitter is on the posterior side of the patient, and the cassette or digital detector is on the anterior of the patient. In the AP or anterior posterior projection, the position of emitter and detector are reversed. And then in the lateral projection, X-ray beams enter through one side of the patient and exit the other, hitting the detector for the creation of the image. So here we have examples of a chest x-ray in both the PA and the AP technique or projection. So in the PA, the emitter is located on the posterior side of the patient, and the x-ray beams pass through from posterior to anterior where the digital cassette is found. Again, this is the posterior anterior or PA projection. And notice how the patient's hands are on their hips and the elbows are forced forward toward the cassette, and this rotates the scapula out of the way of the apices of the lung fields so that they can be clearly viewed on the x-ray film. This is in contrast to the anterior posterior or antero-posterior or AP projection, in which the emitter is on the anterior side of the patient. X-ray beam passes through from anterior to posterior, and the cassette or digital detector is inside the bucky. The bucky is that structure which holds the cassette, in this case on the posterior side of the patient. So the AP projection is used commonly when the condition of the patient is such that they are unable to stand, as the patient would need to stand for the PA technique. This is really an important rule that you need to understand, and what it is that regardless of how the image is taken, regardless of the projection, in a coronal or frontal, coronal is abbreviated COR, in the coronal or frontal image or slice, the image is viewed or oriented on the film as if the patient is facing you. So this is with reference to anatomical position. So the film is always oriented, or the image is always placed on the film with reference to anatomical position. In the lateral projection, this is a little bit different. Say, for example, we have a patient in which we suspect that the patient might have some neoplasm in their chest, in their thorax. So we take a chest film and we see a nodule or suspected mass on the left side, so somewhere within the left lung. So now we would use a lateral projection, because this would allow for better viewing, a better image of a lesion or anomaly that is confined to one side of the body, in particular the chest. In the lateral projection, we have the side of the patient that contains the lesion, in this case the left side, against the cassette or the bucky containing the cassette, and the emitter is on the contralateral side. And this stands to reason, because then as the X-ray beam photons travel through the path of the body, they'll hit the massive tissue and be attenuated more, and therefore the image or the lesion that's confined on that one side of the body will create a better image for us to interpret on the film. Again, this is the lateral projection, and it is usually a technique that's utilized for viewing of a lesion that's confined to one side of the body, and usually in the chest. This, you might say, is another take-home slide, because it contains information that you really need to get into memory. When we look at films, it doesn't matter what film, what kind of radiograph we're looking at. We can classify abnormalities into specific categories, and the categories that we use are number 1, too black, number 2, too white, number 3, too large, and number 4, in the wrong place. Too black and too white really refer to those properties of transmission, attenuation, etc. And those depend on atomic number, how much of the energy or the strength of the beam is being absorbed, the density of the tissue, etc. too large and in the wrong place rely on your knowledge of anatomy and anatomical relationships within a region of the body. So for these two, you have to have some foundation in anatomy. So how do you gain the most information from any radiograph? My suggestion to you is that you adopt the following procedure. Number 1, always check the name and the date on the film. It's important that you never forget the patient. You need to know who you are reporting on, and you need to know the date, because a patient's condition and therefore their radiographic status may change over time. Number 2, you want to understand the orientation. This is critical. Understand which is left, right, superior, inferior. What is the projection that was used, etc. If you do not understand the orientation, any interpretation that you make will be valueless. And even more dangerous, your interpretation may be used then to treat the patient and may result in the wrong treatment for that patient or doing harm to that patient. So always understand the orientation. Then you want to check the technical quality of the film. For the most part, this will be done by the radiographer. Some of this might be done by a radiologist, but it's important for you to know how to check the quality of a film, the technical quality of the film, so that you have some basic working knowledge that will assist you in knowing that the interpretation that you are making is accurate for diagnosis of your patient. Next, you want to scan the film thoroughly, and you want to mentally list any abnormalities that you find. You always want to make sure that you complete this stage. When you find abnormalities, you want to work out where they are. And again, for this, you need to have some working knowledge of human gross anatomy and anatomical relationships. Then you want to describe the abnormality. Into which category does it fall? Is it too black? Is it too white? Is it too large? Or is it in the wrong place? Always ensure that the film you are looking at is reported on by a radiologist. And lastly, never forget the patient. A very sick patient can have a normal chest X-ray. Now that we have the basic building blocks for our understanding of medical imaging, let's build a foundation of knowledge by looking at various radiographic modalities. And the first radiographic modality that we are going to discuss is the chest X-ray, or CXR. The chest X-ray is really a composite of images cast by the soft tissues and bone of the thorax. It is the most frequently used radiograph and most frequently taken in the posterior, anterior, or PA projection. This is the standard. So the emitter is behind the patient as they are standing, and the cassette, or the bucky containing the cassette, is on the anterior aspect of the patient. And you ask the patient to put their hands on their buttocks, or more commonly on their hips, and to press their shoulders forward toward the cassette. And this rotates the scapula, or the shoulder blade, out of the apices of the lung field so they can be clearly visualized on the X-ray film. This is in contrast to the AP, or the anteroposterior projection, in which the beam is fired from the front of the patient, and the cassette is placed against the posterior aspect of the thorax. And then, of course, we've already mentioned the lateral projection, which is used for better viewing of a lesion that is confined to one side of the chest. In this case, beam enters one side of the thorax, leaves the other side that is placed against the cassette. It is important that the patient lift their upper extremities above their head so that the view of the thorax is not obstructed by the bones of the upper extremity. Here are some images of actual patients being photographed as they are having their chest x-rays done by the radiographer. On the left, the PA projection chest x-ray technique. On the right, the lateral projection chest x-ray technique. In the PA projection, beam passes from posterior to anterior. The hands are on the hips and the elbows are pressed into or toward the cassette, and this rotates the scapula or shoulder blade out of the way of the apices of the lung fields. In the lateral projection, beam enters one side of the patient, exits the other, which is the suspected lesion containing side of the patient's chest, which is against the cassette or detector. And it's important, of course, that the upper extremity is held above the head so the bones do not obstruct the view of the thorax. This is an example of a standard PA chest film obtained from a patient. The difference in the film on the left versus the film that's shown on the right, same patient, same film, but the film on the right, the contrast has been inverted. So what would have normally appeared as bright or white or radio opaque is now radiolucent, and what would have appeared as dark or radiolucent now appears as white or radio opaque. Sometimes this is done and the films are put side by side, and when we do this, it's often easier to visualize some abnormality that we might otherwise miss with the human eye. Again, the regardless of the projection, it's a coronal slice, so it is placed on the film or on the monitor as if the patient is facing us with reference to anatomical position. Although we do have the Mitchell marker here, so this is right and this is left, this is superior, this is inferior. If I didn't have this here indicating that it was a PA film, I would know that because the scapulae or the shoulder blades are rotated out of the way of the apices of the lung fields. The border or the vertebral border of the scapula is almost even with the border of the ribs that we're seeing here. I'm pointing this out to you using the laser pointer. We see the radiolucency of the lung fields because they're mostly filled with air. Costodiaphragmatic recess, I'm outlining here for you bilaterally. We have the dome of the diaphragm over the liver, the dome of the diaphragm over the stomach. This is a gas bubble, a gastric air within the stomach. Radiolucency of the trachea, so air in the trachea. You can see the vertebral column. And this is the cardiac silhouette. Because the heart is an anterior structure, how it appears on film will differ depending upon where it is placed relative to the emitter or the source of the X-ray beam and the detector or the cassette. For example, if we look at the diagram in the lower right part of the slide, okay, in the AP projection, the heart is further away from the detector are closer to the source. So as the beams pass through the patient, what happens is the apparent size of the heart is magnified or is increased. So this is one reason why it is important to understand which projection was used. If you didn't know that the AP projection was used, in this case, you might suspect that there's some kind of cardiac problem in this patient. This is in contrast to the PA projection, in which the heart is closer to the detector and further away from the emitter. So the apparent heart, or the apparent size of the heart, is smaller. And for this reason, we need to have a standard that is used in medicine. And that standard is that the preferred or standard projection for the chest X-ray film is the PA projection. So not only is the chest X-ray the most commonly used radiograph, but it is most commonly taken as the standard in the PA projection. So once you, as the physician, know the name of the patient and the date, so you know who you're reporting on and when you're reporting on, and you get your orientation with reference to anatomical position, then you begin assessing the technical quality of the film. Part of that is understanding the projection, whether we have AP versus PA, and how this may or may not affect the image. We already understand how this may affect the appearance of the cardiac silhouette or the heart shadow in one way. Okay? In the AP view, the heart will appear bigger because of its position relative to the emitter or the source of the X-ray beam and the detector or the cassette. If we look at the film here on the right, this is a chest film, and it is in the AP view. How do I know that? Because I can see the border of the scapula, the vertebral border, within the apices of the lung field. Really clearly seen here on the left. So the heart silhouette may look abnormally large. This is in contrast to the PA projection, in which the scapula has been rotated out of the way of the apices of the lung field. Here, just about even with the border, the lateral border of the thorax. And just by rotating the scapula out of the lung field and changing the projection, we can see a difference in the size, not only the diameter of the cardiac silhouette, but the length in terms of going along the longitudinal axis. So it's important to know projection before you make an interpretation about the film, because that may affect your understanding of the cardiogenic status of the patient. Another aspect that may affect how the patient's cardiac silhouette appears on the film is inspiratory effort. And the standard that is used is the PA projection. And usually a film is taken during a full inspiration. And to judge the degree of inspiration, we count the number of ribs above the midpoint of the right hemidiaphragm. So right along this area here, indicated on the image on the left using the laser pointer. Okay. The number of ribs that can be counted should be between 5 and 7 if we're using the anterior component of the rib. If there are more than 7 ribs, the patient is hyperinflated. If there are fewer ribs, the patient is underinflated or hypoinflated, and this may result from pain, exhaustion, disease, or even fracture of the ribs or other aspects of the thoracic cage. If a patient is underinflated or they are hypoinflated, then this will also cause the cardiac silhouette to appear larger and may also cause the trachea to deviate to the right. This is the anterior aspect or component of the rib that's used if you're counting between 5 and 7 ribs that should appear over the midpoint of the right hemidiaphragm. This is one method that is used. You can use the posterior component of the rib. The posterior component of the rib looks as if it's coming out towards you out of the film, versus the anterior component, which looks as if it's going away from you into the film. However, if you use the posterior component, secondary to the angle of the rib and how the rib curves around the thorax, then the number that we look for is between 7 and 9. Neither method is more accurate than the other, but you should choose a method and stick to that method when you make your interpretations. I like using the anterior component. So if we count the number of ribs above the right hemidiaphragm on this upper chest film, we have 1, 2, 3, and 4. So we have 4 ribs, so the patient is underinflated. And if we look at the cardiac silhouette, it looks like it's shortened or squashed and a little bit wider. So the patient is hypoinflated. If we look at the film below, we have 1, 2, 3, 4, 5 ribs and part of 6 that are at the midpoint of the right hemidiaphragm. Okay? So the patient is adequately or normally inflated. So we have a normal inspiration. And look at how the cardiac silhouette has changed shape. It's more elongated and it's not as wide. So always understand the projection that's being used. Always make sure you understand the orientation and check for left-right markings or Mitchell markers. Make sure that you understand if the patient is hypoinflated, hyperinflated, or has a normal inflation of the lungs. And then you also have to assess for rotation or degree of rotation. Okay? To identify or determine if the patient is rotated, you look for the medial end of the clavicles, okay, and select one of the vertebrae and locate the spinous process or processes on the vertebrae that falls between them. The medial ends of the clavicle, or even the midpoint on the clavicle, should be equal distant from left to right with reference to the spinous process. If one side is shorter or has a shorter distance than the other, then the patient is rotated to that side. And this is important because the lung on that side will appear whiter or more opaque. Why? Because as the x-rays pass through the body and the patient is rotated to that side, there's actually more tissue or tissue density on that side of the body relative to the cassette for the X-ray beams to pass through. And as the photons or the X-ray beam becomes more attenuated, that part produces then a whiter or more opaque image on the film. You should also check for the degree of penetration, which is related to the exposure or the amount of strength in the X-ray beam. And to do this, you look at the lower part of the cardiac shadow or silhouette. And within this silhouette or shadow, the vertebral bodies should only just be visible through the lower part of the cardiac silhouette. If they're too clearly visible, then the film is over-penetrated or overexposed. That means the beam strength that was used was too high. And in this case, you might miss a low-density lesion. In contrast, if you cannot see the vertebra at all, then the film is under-penetrated or underexposed. So beam strength was lower than what should have been used. And in this case, the lung fields will appear falsely white, which may obscure a lesion as well. I've mentioned the cardiac silhouette or cardiac shadow several times now. Sometimes we refer to this shadow or image on the film as the cardiovascular shadow, or collectively mediastinal silhouettes. This is the image that appears on the film that contains the heart and vessels within the mediastinum, that space that's between the lungs. Okay? The borders of this cardiovascular shadow or silhouette are always viewed in the PA projection, and changes in the shadow or the borders may indicate some kind of anomaly or functional disease, and therefore the chest X-ray can give us critical information regarding the cardiogenic status of the patient. So this is a diagrammatic view of the cardiovascular shadow or the mediastinal silhouette. And what we've labeled here are the different regions of the left border, representative of the aortic knob or aorta, the pulmonary trunk, the left auricle or atrium, the left ventricle, and sometimes, depending upon the quality of the film, we can see some extra pericardial fat, all on the left border. In contrast to the right, where we would see the right brachiocephalic vein or trunk, the superior vena cava, the right atrium, and the inferior vena cava. Now, you notice that the right ventricle is not listed as part of the border, and that's because the way the heart is situated within the mediastinal cavity of the thorax is such that the anterior surface of the heart is mostly made up of the right ventricle. And then depending upon how the patient is oriented and the beam goes through the body, this may also change the way the borders of the silhouette appear. But if we look in our standard PA projection and label the borders, we have the aortic knob, the pulmonary trunk, the left atrium or auricle, and the left ventricle, not labeled here, the extrapericardial fat, the brachiocephalic trunk, superior vena cava, the right atrium. We don't really see much of the inferior vena cava here because of its overshadowing with the rib, and of course the right ventricle makes up most of the anterior surface of the heart. These are some other chest x-ray films that I've placed in the presentation for you, and I've labeled some of the important landmarks such as the clavicle, some bony structures, the scapula, spinous process or spinal process of the vertebral bodies, the trachea, the radiolucency, anterior component of the rib. We can see the bifurcation here of the trachea, which is known as the carina, the hilum of the lung. So we have the left bronchus here with its hilum. We see part of the descending aorta. This is a female patient, so we also see the soft tissue of the breast, the gastric air bubble, and the liver and the dome of the diaphragm over the liver, as well as the posterior component of the rib and the right atrium. And in the diagram on the left, we've overlaid a drawing of the heart and mediastinal structures, as well as the lungs and their fissures. So we can see the area of the manubrium, superior vena cava, the bronchus, horizontal fissure, where that would be on the right, as well as the oblique fissure, costodiaphragmatic recess, inferior vena cava, the oblique fissure on the left, separating the superior lobe or upper lobe of the lung from the inferior lobe. Again, the dome of the diaphragm over the stomach here with the gastric bubble. This is the left costodiaphragmatic recess or costophrenic angle compared to the right. There are a few other structures that you can view here on your own time. Here, in this case, we've done the lateral projection and overlaid a diagram, so you can see that the extremity has been rotated up out of the way. Okay? We have the bronchus, scapula, atrium, left atrium in this case, and left ventricle. So the left side of the patient is against the cassette, manubrium and sternum, right ventricle, which we already said makes up most of the anterior surface of the heart, the gastric bubble, and the left and right costodiaphragmatic recesses. And you can see a nice lateral view of the spinal column with the radiolucencies indicating positions for the intervertebral discs. If we examine the cardiac silhouette in the standard PA chest X-ray, it can give us information about the cardiogenic status of the patient. We can determine some of this information through the use of the cardiothoracic ratio, which is a simple method to obtain a rough estimate of the heart size, and it is calculated from the PA chest film only. As the chest film at the right shows, the cardiothoracic ratio would be the distance from A to B, or the width of the heart, over the distance from C to D, or the width of the thoracic cavity, and it should be no more than 50% in a healthy individual. Another way to measure the cardiothoracic ratio is from point A to midline, and that should fit in the line created from B to D. I prefer the ratio of A to B over C to D, and again that should be no more than 50%. Looking at this film, can you determine the cardiothoracic ratio? If we examine the film, we draw a line from A to B, place it over the distance from C to D, and clearly the cardiothoracic ratio in this patient is greater than 50%, and it is indicative of both left and right-sided cardiomyopathy or heart failure. Now this gives us a classic goblet shape or flask shape to the heart, and it may be that some of this shape is due to pericardial effusion, and we determine that by comparing the PA view with the lateral view in the same patient. Let us examine this chest film. And if you look at this chest film, is there something abnormal about the cardiothoracic ratio in this patient? If you guess that it is normal, you are correct. First of all, you need to realize that this is not an adult patient, but it is a child. We can visualize this or interpret this by looking at the funnel-shaped thoracic cage, and if we look at the heads of the humeri bilaterally, they are not yet ossified. So what I'm outlining now is the cardiac silhouette. And then here on the right side and overlapping with part of the cardiac silhouette is the thymus gland. So it's important that we understand that the mediastinal silhouette in a young child is overshadowed by the shadow of the thymus so that no misinterpretation can be made regarding the cardiogenic status of the adolescent or child patient. Is the cardiothoracic ratio normal in this patient? If you answered yes, you would be correct. This is also a child, as we can identify from the funnel-shaped thoracic cavity, yet it's a little less funnel-shaped than in the prior film, and the thymus gland has become more residual. So outlined here then is the cardiac silhouette. It might look like it's a little bit wider than it should be, and that would indicate that something is going on in the patient. But if we look carefully in this area right here, we see a rib fracture. Whenever we see a rib fracture in a young patient, such as a child, we always must include the differential diagnosis of child abuse in our assessment. Let's try to interpret another chest film. You are the physician. What is the diagnosis? It's always useful when the image given to us has an arrow on it, as here on the left side of this film. So if we get our orientation, this is left and this is right. And there's a lot of heavy white haziness, but for all practical purposes, we can interpret what we need to do in this film, although it is underexposed. And right at the arrow here, you see the border of the lung, the left lung, that has separated away from the thoracic wall, and it's very dark here. And this is an example of a left-sided pneumothorax. So what is indicated by the arrow would be the border of the lung as the air is entering the pleural cavity. What would be the signs and symptoms of pneumothorax? Well, it would be increased difficulty in breathing, and of course if you look at a chest film over time, you might see a decrease in opacity or an increase in radiolucency in the area of the pneumothorax. As far as the mechanism, there are several, but most common, there is some kind of blunt trauma to the chest, but you can also have a spontaneous pneumothorax without blunt trauma. And how would you treat this injury in the field before and during transport to medical control? Of course, you would give oxygen and try to stabilize the patient during transport. Let's try one more. What is the diagnosis in this patient? Here we have two films of the same patient taken at different moments in time, one during inspiration and the other during expiration. And what we see during inspiration is a greater amount of air is entering the thoracic cavity or the pleural space on the right side of the patient. Air is less dense or least dense in terms of radiographic densities, and therefore there's a greater area of radiolucency here on the right side of this film. As the patient expires, air becomes trapped inside the pleural cavity. And gradually over time, this repeated cycle of inspiration, expiration, and trapping of the air in the pleural space, the air builds up and pushes the mediastinal contents to the contralateral side of the body. And this condition is known as tension pneumothorax. The signs and symptoms that we see in this case are often redness or purplish color in the face and neck and distension of the neck veins. The mechanism of injury, again, is usually some kind of blunt force trauma leading to an open chest wound or a sucking chest wound where air enters through the thoracic wall or the wall of the thoracic cage. How do you treat this injury in the field? Of course, you would give oxygen, and you would more than likely add to the patient or attach to the patient over the sucking chest wound a Vaseline gauze bandage that's adhering to the skin on 3 of the 4 sides, and this would keep air then from becoming trapped in the pleural space through the sucking chest wound. These are 2 other plain X-ray films. The one on the left is a lower GI or gastrointestinal film with barium enema. It is a single contrast technique. So a catheter of one type is inserted into the rectum, and the barium, which has a metal contrast agent in it, is injected into the rectum and the large colon. And we get a nice image. We have the cecum, the ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, rectum, and out to the anus. In the image on the right, this is a cystogram or a radiographic image of the bladder. The technique is known as cystography. So a catheter is inserted into the urethra and the contrast agent is injected, and we get a nice picture of the urinary bladder. This happens to be a male patient. We know that because the male urethra is longer than we would see in the female patient. Like any method, there are advantages and disadvantages, and with respect to the X-rays, the advantages are that they are relatively inexpensive. They can be performed pretty much just about everywhere, and the results are fast and they are easy to perform. The disadvantage, the main disadvantage, is that the patient is being exposed to some radiation. You also might need to use some kind of contrast agent in some forms of imaging to get a better image for you to analyze and interpret. An example might be an iodine contrast or some other radiopaque solution that's injected into the vascular system to get a good image of the kidneys, such as in a renal pyelogram. Contrast is not as good in an X-ray as you see in a computed tomography, a CT scan, or an MRI. And sometimes you may miss some abnormalities or some lesions that might be better visualized using these other techniques. Now, let us briefly discuss fluoroscopy. Fluoroscopy is a medical imaging technique that is similar to X-rays, but in this case it shows moving images of the internal organs rather than still shots. So we can look at the movements of different organs, such as the lungs and the heart, etc. And it can also be used for cardiac catheterization and angiography. And actually, outside of cardiac catheterization, it is really no longer commonly used. Fluoroscopy can be used to diagnose disorders of the gastrointestinal tract, blood vessels, and some other organs. It can also be used to place stents to open up blocked blood vessels, such as in coronary angiography. And you can insert catheters in through the urinary system, blood vessels, and bile ducts. It also aids orthopedic surgeons in the repairing of fractures and the positioning of joint replacements. Basically, X-rays impinge on the input screen of an image intensifier, and this intensifier is coupled to a television camera where you can see live images of the patient's internal organs. During this process, an X-ray beam continually passes through the body, capturing images of structures and the motion of body systems in real time. Typically, the patient lays on a table while the machine transmits beams through the patient to the monitor. And depending upon the organ that is under examination, a doctor may insert a catheter or a contrast dye to improve the clarity of the image being obtained. The patient also may be asked to change position periodically. This is an example of an image of the GI system, the stomach, on the input screen. And the patient here is drinking a barium meal to increase the contrast in the image. In the procedure known as cardiac catheterization, fluoroscopy is used to visualize the insertion of a catheter into an artery, usually into the femoral artery, up through the common iliacs and the descending aorta, through the aortic arch, and into the coronary vessels. The catheter can also enter the heart, where the physician, or in this case the interventional radiologist, can measure intracardiac pressures, take blood samples or tissue samples for analysis in heart transplant patients, get a real-time movie of the heart in contraction, or perform a balloon angioplasty or stent insertion into one of the coronary vessels. This is a freeze-frame image of coronary angiography. Indicated by the arrow is the catheter going up the thoracic aorta. Somewhere up here off of the film would be the aortic arch, and then the ascending aorta coming down into the opening of the right coronary artery where dye is injected. So we see the right coronary artery, the posterior interventricular branch, the posterior interventricular branch coming off of the right coronary artery, and the sinoatrial nodal artery. A similar method can be used for aortogram or aortic angiogram. And this is what this other image is showing. We have the catheter coming up through the descending aorta, the aortic arch, and the ascending aorta. The dye is released and it goes into all of the branches coming off of the aortic arch. The reason that this is dark is that the contrast has been switched using the computer, so what normally appears as opaque or white is now dark or radiolucent. And through the magic of PowerPoint, I have gone in on the film and I have labeled all the vessels for you. And we don't expect you to know all these at this time, but by the end of the course, you should be able to identify these vessels on the aortic or aortogram, aortic angiogram. There are two radiographic techniques that can be used to visualize the trachea and the bronchial tree. These are bronchography and bronchoscopy. Bronchography is a radiographic modality that involves using X-rays to visualize the tracheobronchial tree. However, it requires the introduction of an oily radiopaque material, usually an aerosol or drip. This substance coats the bronchial tree so that it can be visualized on plain X-ray film. So here we have the catheter being inserted into the tracheal bronchial tree, and the aerosol or oily radiopaque material is injected and then adheres to the mucus lining the tree. It is mostly not used now, secondary to the advent of high-resolution CT scan and bronchoscopy. Bronchoscopy is a technique that is used to view the airways and in some cases diagnose lung disease. In some instances, it may also be used during the treatment of some lung conditions. During bronchoscopy, the physician will insert a tube with a camera into the throat, the trachea, and the bronchial tree. In this manner, the physician can observe the throat or pharynx, the larynx, the trachea, as well as the lower airways. This is an example of what might be visualized using the bronchoscope. Here we see the carina, or the point at which the trachea divides into left and right main bronchi. Computed tomography bronchography is a technique that utilizes X-ray beams, but also high-resolution computed tomography to examine the tracheal bronchial tree. Detailed images of the trachea and all of the branches of the bronchial tree are produced using this technique. Computed tomography, or CT scan, also known as CAT scan, is a computerized X-ray procedure that produces cross-sectional images, axial images, transverse or horizontal images of the human body. These images are far more detailed than X-ray films and can reveal disease or abnormalities in tissues and bone. The procedure is usually non-invasive and brief. However, contrast agents may also be used during the CT scan. CT scan is based on the X-ray principle that as X-rays pass through the body, they are attenuated at different levels, creating a matrix or profile of X-ray beams of different strength. The X-ray profile is registered on film, thus creating an image. In the case of CT, the film is replaced by a series of banana-shaped detectors, and there is one emitter. The detectors and the emitter rotate around the patient, that is in supine position within the CT tube. Thus, several beams of X-rays are sent through the patient simultaneously at different angles, creating ultra-thin cross-sectional images with very high detail. In a CT scan, the patient is placed in supine position on a motorized table that will move the patient in and through the CT tube. The CT tube contains the banana-shaped detectors and the X-ray emitter that spin around the patient. Low-intensity X-rays pass through the patient from many different angles, and they are collected and then processed by a computer. The higher the number of detectors and the more slices that are taken, the better the resolution. Series taking in one view can be manipulated using computer technology known as multiplanar reformatting. Thus, a CT scan taking an axial view can be converted to coronal or axial to sagittal, etc. Typically, as a patient passes through the CT tube, it is an axial series that is taken, and then multiplanar reformatting is used to generate other views. Just as with plain X-ray films, CT scanning also involves various radiographic densities. These densities in CT imaging are expressed as Hounsfield's units, or HU, with air being least dense and compact bone being most dense, with a variety of tissues in between containing different amounts of water. That makes sense in terms of the contrast or the densities that are produced, because all of this is standardized to the radiodensity of distilled water. In a conventional X-ray, a broad beam of X-rays is passed through the patient. This is in contrast to CT, in which a thin beam of X-rays is passed through the patient that is absorbed by a detector. These two images show various slices obtained from a CT scan of a patient's head. On the left is an axial scan, and it's nice that the radiographer gives us the insert on the left lower corner of the film that shows us the plane of section, or the plane of the axial slice. This is anterior and posterior, left and right. So we have the nasal septum, nasal concha, maxillary sinuses, and the nasopharynx, mastoid air cells. The slice on the right is of the head, but in the coronal view. Again, note the insert on the lower left of the film showing us the plane of slice. Here we see the supraorbital margin, the nasal septum, nasal concha. This gray tissue is mucous membrane, some inflammation here, maxillary sinus, sphenoid sinus. Here is a CT scan in the axial view of the superior abdomen. Axial is the same as transverse and the same as horizontal. In the United States and North America, when viewing an axial slice of a CT scan or an MRI scan, you are always viewing the slice as if you are viewing or looking from the patient's feet. The patient is oriented then with reference to anatomical position on the film. So then, this is anterior, below is posterior, this is left, and this is right. And in this film, what do we see? This is a thoracic vertebral body. We can see the attachment of the head of the rib, or I should say the articulation of the head of the rib, the spleen, the stomach with the gastric bubble or air bubble, the liver, inferior vena cava, abdominal aorta, crux of the left diaphragm and crux of the right diaphragm, some of the transverse colon containing gas, and we see some fatty mesentery containing vessels going to and from the hilum of the spleen. Posteriorly, we can see the erector spinae group of muscles bilaterally. Finally, we see the spinal cord within the canal of the spinal column. The advantages of using CT include that they produce a sharper image than X-ray imaging, and there is also good spatial resolution. They are very useful in showing bony structures and bony lesions or calcifications in soft tissues. The procedure is relatively rapid, and it can be used on individuals that also have metal in their bodies, such as pacemakers, screws, hip or knee implants. And it provides a wider field of view than with another technique known as ultrasound. The disadvantages are that the cost is more expensive than that of the conventional X-ray. There is still radiation exposure, and the radiographer may still have to inject a contrasting agent into the patient or have the patient swallow a contrast agent, such as a barium meal. There is limited contrast with respect to soft tissues in that it is not as clear as MRI or magnetic resonance imaging. Let's move on now and talk a bit about magnetic resonance imaging, or MRI or MR. This technique involves the use of magnets and radio waves and a computer to produce images of the body structures. No X-rays are utilized. The MRI scanner is a tube known as the gantry, and the gantry is surrounded by a large magnet. The patient is placed in supine position on a movable bed into the magnet. The magnet creates a magnetic field which aligns the protons of hydrogen atoms within the patient, which are then exposed to radio waves. This changes the spins of the protons, and as they return to their normal energy levels, they emit signals that are detected by detectors around the magnet. This information is transferred to a computer, and an image is then produced. Again, a motorized table moves the patient into the gantry. The gantry contains a magnetic assembly. A field is generated that temporarily aligns the hydrogen atoms in the body. Pulsed radio waves cause these atoms to produce very faint signals, which are then collected and analyzed to produce cross-sectional images. Open MRI can be used for individuals who are claustrophobic. And the images that are reconstructed by these techniques can be produced in any plane. This is similar to multiplanar reformatting. Most recently is vertical MRI, in which a patient can be in the seated position while the MRI scan is being taken. Again, if interpreting an axial view or slice of an MRI in a patient who is in supine position, our view is from the inferior perspective. Depending on the pulse sequences that are used, we can change the contrast in the film. This is called T1 or T2 weighted imaging. This affects the appearance of some of the tissues. In T1 weighted images, there is longitudinal regrowth of spin lattice relaxation. This occurs as the spins give off their energy to the molecular environment and return to their lower energy state. As a result, fluid is dark and tissue is white. This is in contrast to the T2 weighted image, which is a transverse or spin-spin relaxation. The result is that fluid is white and tissue is dark. So the take-home message is that there is different weighting used on MRI imaging, which is basically changing the contrast. In a T1 weighted image, fluid is dark and tissue is white. In a T2 weighted image, the fluid is white and the tissue is dark. These images show sagittal views of a patient's lumbar spine, both using T1 weighting and T2 weighting. In T1, fluid, or the CSF surrounding the spinal cord, is dark, and fatty tissues are bright. This is in contrast to the T2 weighting, where the CSF or fluid surrounding the spinal cord is bright and the fatty tissue is intermediate to bright. On the T2 weighted image, if we also examine the intervertebral discs, we also can see that they are varying degrees of brightness. This is because the intervertebral discs are hydrated, and as we grow older, they become dehydrated. Different discs have different levels of hydration, and this is suggestive of degenerative disc disease that can lead to disc herniation. These are mid-sagittal MRI images of a patient 6 months after spine radiation for breast metastases who now presented with new pain and a positive radionucleotide bone scan. Images are both T1 and T2 weighted. The arrow indicates the focus of a new lesion or new metastases, and of course in the T1 weighted image, fluid is dark and tissue is bright. In the T2 weighted image, fluid is bright and tissue is dark to intermediate gray. With MRI, tissues appear differently depending upon the weighting and their fluid content. Fluid in a T1 weighted image appears dark, whereas in T2 it appears very bright. Air tends to be black or dark on both T1 and T2 weighted images. Muscle, intermediate in T1 versus intermediate to dark on T2. Tendons, which tend to be avascular, are very dark. Cortical bone is black. Bone marrow is bright in a T1 weighted image, but intermediate to bright on T2, and fat in a T1 weighted image tends to be bright and intermediate to bright on T2 weighted imaging. T1 weighted images are very good for demonstrating anatomy because tissue with high fat content appear bright and compartments filled with water appear dark. This is in contrast to T2 weighted images, which are very good at demonstrating pathology because most, but not all, pathological lesions are associated with an increase in water content. And remember, water or fluid is bright on T2, or in the case of the patient, wet tissue is bad tissue. There are many other imaging weighting techniques within MRI, such as T3 Tesla and diffusion weighted, as well as perfusion weighted imaging. These techniques, however, are beyond the scope of our discussion here. This is an MRI scan at thoracic vertebrae level number 5. Not very high resolution. We see the fatty tissue of the breast, some fibrosis or ligaments in the mammary tissue, pectoral musculature, the lung fields, thoracic vertebrae with spinal cord and cerebral spinal fluid, erector spinae muscles, thoracic aorta, and heart chambers. Here are images with somewhat better resolution at vertebral level T9 and T10. At T9, we're still just above the diaphragm, so we can see part of the right lung field and the left lung field. This is the heart, this is the right ventricle, and the left ventricle. You can see the thick left ventricular wall. Thoracic vertebrae, thoracic or descending aorta. At level T10, the vertebral body gets a little bit wider. Descending aorta or abdominal aorta in this case. Liver with vena cava. Stomach with the gastric bowel and part of the spleen, and erector spinae musculature. In this first image, we have an MRI of the cervical spine or C-spine, and in this case the weighting is that of T2, where fluid is bright and tissue is dark. We see differing degrees of disc dehydration representative of degenerative disc disease. We can also see the cerebral spinal fluid around the medulla oblongata, the pons, and in the fourth ventricle, also in the cerebellomedullary cistern. In this image below, we have a transverse or axial section at the lumbar level. We can identify this because of the wide vertebral body. These are the erector spinae musculature. The next image, a mid-sagittal image, MRI of the thoracic spine, showing varying degrees of degenerative disc disease. Again, T2 weighted, fluid is bright and tissue is dark. And in the final panel, this is a coronal MRI scan of the thorax and upper abdomen. See the lung fields, some of the bronchi, the dome of the diaphragm over the stomach and spleen, and the dome of the diaphragm over the liver. And we see some intervertebral discs and vertebral bodies. This is also an MRI scan, but it is an MRI-V or venous MRI, where we use computer technology to subtract out that which we do not want to look at. So here then we are visualizing the venous system of dural sinuses in the meninges of the brain. An MRI-V of the brain, and we've labeled the different structures here: the superior sagittal sinus, the sigmoid sinus, the transverse sinus, and the confluence of sinuses. And we also have a marker indicating that we are viewing from the left. Functional MRI, or fMRI, is a more recent technique, and it measures dynamic changes in blood flow in the brain. Changes in the blood flow are related to changes in brain activity. So in essence, functional MRI is an indirect measure of the neuron activity in the brain. So this kind of MRI not only shows brain structure, but provides information about brain function, in contrast to the ordinary MRI, which only gives us information about brain structure. In functional MRI, schematics are produced like the one shown here, and the different intensities or brightness of color indicate different degrees of brain flow, and this blood flow within the brain, and the blood flow changes in different regions of the brain depending on the task that the brain is required to complete. The advantages for use of MRI include that they are very good for visualizing soft tissues, and they produce clear, sharp images. They use magnetic energy instead of X-ray radiation, and there's usually no need for contrast material, but it can be used to enhance the image. The disadvantage is one of cost. They are much more expensive than a CT scan. A CT scan on average may range from $3,000 to $5,000 for the area of the body being scanned, and an MRI could be double that. Dense structures such as bone may not show up well on MRI in comparison to CT. Claustrophobia is a problem in that the patient must lie still during the scanning process inside the gantry. However, recently we have the advent of open MRI or vertical MRI for those patients who suffer from claustrophobia. Scanning time is slow. It may take, on average, from 30 to 45 or even 60 minutes and sometimes longer to complete a scan. And an MRI machine cannot be used if the patient contains some kind of ferromagnetic metal, such as screws or pacemakers or hip replacements, or tattoos that are greater than 20 to 25 years of age, because at that time they used pigment in the tattoo that had iron inside it, and if placed into the MRI machine, the iron pigment will be ripped from the patient's skin. Ultrasound or sonography is a technique that is increasingly being used in clinical medicine, and it is also encroaching on the research laboratory. Ultrasound technology utilizes high-frequency sound waves that are produced by a transducer, a handheld transducer that is held against the patient's body or skin. Occasionally, the transducer can also be inserted internally. These sound waves are reflected back toward the transducer at interfaces between tissues of different density, and an image is constructed based on the length of time that it takes for the echo to be received by the transducer, as well as the strength of the echo. The image then is projected onto a screen where it can be annotated and saved for later interpretation. When we speak of echogenicity, we speak of the ability of a tissue to transmit or reflect an ultrasound wave in the context of surrounding tissues. Hyperechoic structures appear white. These include ligaments and tendons, as well as peripheral nerves. Hypoechoic structures appear gray and are inclusive of adipose tissue or fat, cartilage, and muscles. Anechoic structures appear black. These include fluid and blood vessels. Bone appears black or anechoic on ultrasound, but has a bright hyperechoic rim. This is because the ultrasound waves cannot penetrate bone, and it casts an acoustic shadow beyond the bone. Here we have bone, or the humeral head, muscle tissue, supraspinatus, and the white rim, or the hyperechoic rim. Here we have liver metastases and a kidney cyst filled with fluid that appears dark or hypoechoic on film. Ultrasound is widely used in obstetrics and cardiology, such as echocardiogram or ultrasound of the heart. It can be used with Doppler technology, so we can also obtain information about rate and volume of blood flow, as well as directionality. It is increasingly used to visualize most internal organs. Sophisticated three-dimensional ultrasounds can be used in obstetrics to produce three-dimensional detailed images of the fetus. In 3D fetal scanning, however, instead of sound waves being sent straight down and reflected back, they are sent in at different angles, and the returning echoes are processed by a computer program, resulting in the three-dimensional reconstructed image. Recently, and increasing in popularity, is the use of a portable handheld ultrasound device, such as that produced by General Electric Health Sciences, or the GE V-Scan. This is the unit shown here in the film. Okay? This can be used by any healthcare provider and comes with a variety of probes. Various ultrasound scans are preset or programmed in, and can also utilize Doppler scanning, cinema, freeze frame, images or full scans can be saved and later annotated. It is suggested that the handheld ultrasound device will eventually replace the stethoscope. Ultrasonography has some very distinct advantages. First, it is quick and easy to perform. It is inexpensive and non-invasive. It's also safe because it does not utilize radiation. You can also see movements in real time and obtain results in a rapid fashion. It's useful for providing guidance during various procedures such as biopsies or nerve blocks, and is widely available. There are some disadvantages though, the largest of which is that there is a steep learning curve with ultrasound. The quality of the images obtained are to a high degree operator dependent, and ultrasound waves cannot penetrate bone. Sometimes images are produced with poor contrast, and ultrasound may not produce good images in obese individuals. Positron emission tomography is also known as PET scan. PET is a nuclear medicine technique, actually a functional imaging technique that is used to observe metabolic processes within the body. The system depicts pairs of gamma rays emitted indirectly by a positron-emitting radionuclide known as a tracer, and this tracer is introduced into the body on a biologically active molecule. One example is fluorodeoxyglucose. This tracer is used to explore the possibility of cancer metastases spreading to other sites, and is the most common type of PET scan in standard medical care, or 90% of the current scans. Three-dimensional images of the tracer can also be produced. The one big disadvantage of the PET scanners is their cost for operation. The cost is so high that often one scanner is shared between many hospitals, such that a mobile scanner is used, or a scanner placed on a truck that travels between sites when a patient is in need. Here are some images obtained from a PET scan of a male patient with lung cancer, and the cancer cells have an increased rate of metabolism of the radionucleotide or tracer, and they show up is very bright on the film. Also the liver with metastases, and some of the tracer being excreted in the urinary bladder. This is the coronal view. Here in the sagittal view on the right, we can see a very large lung tumor, and we see some tumors at a different level in the lung in the axial view. The last technique for discussion in this presentation is fusion technology. In fusion technology, we combine a PET scan and a high-resolution MRI scan, or a PET scan and high-resolution CT scan, or a high-resolution CT scan and ultrasound. We use the computer to fuse images together. It is largely used in the academic and research settings, but can also play a crucial role in the fine detail of brain imaging, breast cancer screenings, and small joint imaging of the foot. This is an example of a fusion image produced by merging a PET scan with a high-resolution CT scan. The product is a fused image that provides for fine localization of tumors in the soft tissues. Before I conclude this presentation, let's have a little fun with some medical imaging. So this is a high-resolution MRI image of a patient's knee. This is an axial section, so this is anterior and this is posterior. This is the patella. This is the distal end of the femur. So the question then becomes, which knee is this if we have an inferior view? Well, using the magic of PowerPoint, I can bisect this knee. I bisect the patella and the distal femur using this yellow line. And then I draw perpendicular lines extending from the yellow line laterally to the end of the condyle on either side. And then I compare the length of these perpendicular lines. Okay? And it appears that the red line is longer than the green line. So through anatomical reasoning, the tibia is the main weight-bearing bone in the leg, and the medial part of the tibia is wider and therefore must articulate with the medial femoral condyle, which should have a wider or broader articulating surface, which means that this would be the medial condyle of the femur, and this would be the lateral condyle of the femur. This is the biceps femoris muscle. And assuming that all that is correct, then we must be looking from below and we must be looking at the right knee. This is a high-resolution MRI scan of a patient's brain in sagittal section, and it is T2 weighted, where fluid is bright and tissue is dark. And then what I've done is I've provided a reference for you with all the structures that are labeled. The difference here is that this image is T1 weighted in the sagittal view, where fluid is dark and tissue is light or gray. So for example, this is the lateral ventricle, this is the corpus callosum, cerebellum, cerebrum, pons, medulla, thalamus, corpora quadrigemini, cerebral aqueduct, fourth ventricle, cerebellomedullary cistern, spinal cord. But you can go ahead and quiz yourself here and identify the structures. These are images of a case that I'm currently working on in my research laboratory. The patient's name and ID numbers have been changed, as well as the ascension numbers and dates. But they are interesting images to examine. The image here on the left is a coronal view of the patient's brain compared to the image on the right, which is an axial view. So we have left and right, anterior and posterior, and on the image on the left, superior or head, inferior or foot, and left and right. And what you're seeing are these light inflamed areas within the parenchyma of the brain, and this is actually a fungal infection of the brain secondary to a comminuted fracture that the patient received when they fell down into some dirty water off of a rocky ravine. So this is an example of blastomycosis, which is a fungal infection from Blastomyces dermatitis, which is an ascomycota. And these are organisms or dimorphic organisms, meaning that they can exist either as yeast or filamentous fungi. And in this case, the infection has spread to the brain. This is a reconstruction done from a CT scan using a software program known as TerraRecon. and we can get very detailed images reformatted in different views of the bony structure, or really of anything that we want. And the program allows us to subtract that which we don't want to view. And we did this because when we took the x-ray of this individual, Dorothy Purcell, we saw that she had densities in the tissue of her leg. And when we looked at this on the CT scan, we saw that it was bone, and we actually did histological sections of her skin and saw bone in her skin. And blowing this up, this is more or less of a trabecular type of bone or cancellous type of bone, and we don't know what caused this development of bone in her skin, and we're currently researching this in our laboratories. Finally, just to recap the things to remember when examining radiographs. You want to remember to comprehend the orientation. If you don't understand the orientation of the film, all is lost. Any interpretation you make will be valueless, and critically, it may lead to harm for your patient. You want to observe the technical quality of the image. Is the patient rotated? Was the penetration high or not enough? Was the exposure too high or too low? Was there adequate inflation, etc.? Look for landmarks to determine the level, to determine where you are in the body. And relate this to your understanding of anatomical relationships. So you need to know what you expect to find, so that when you find something that's abnormal, you realize it's there. And you want to classify the abnormalities. And remember, our classifications are too black, too white, too large, or in the wrong place. And too large or in the wrong place rely on your knowledge of human gross anatomy and anatomical relationships. To gain the most information, you should adopt the following procedure. Number 1, always check the name and the date. Know who you are reporting on and when you are reporting on that patient, because a patient's radiographic status will change over time. Again, understand the orientation, which is a critical step in the procedure. Check the technical quality of the film, and scan the film thoroughly and mentally list any abnormalities that you find. You want to always be sure that you complete this stage. When you find abnormalities, work out where they are based on your knowledge of anatomy and anatomical relationships. 6. Describe the abnormality. Into which category does it fall? Is it too dark? Is it too light? Is it too large or in the wrong place? Always ensure that the film is reported on by a radiologist. And lastly, never forget the patient. Understand that a very sick patient can have a normal chest X-ray. I'd like to acknowledge the following individuals and institutions in helping with resources that have gone into creating this presentation. First, the former and current president and CEO and the director of imaging services at Methodist Hospitals of Northwest Indiana, the Department of Radiological Sciences at the Indiana University Northwest Campus in Gary, Indiana, and Prompt Ambulance Service in Highland, Indiana, the prosectors, physicians, and participants of the International Human Cadaver Prosection Program at the Indiana University School of Medicine Northwest in Gary, Indiana. and my greatest degree of respect to the contributions and gifts of the first patients and their families to medical education and scientific research. I thank you for participating in this discussion on medical imaging and encourage you to review the content herein. If you have any questions, please do not hesitate to contact me. I will do my best to answer you.